Karnvir. I'm a first-year internal medicine resident, and like Dr. Freed said, I'll be presenting my Mythbuster on estrogen replacement therapy in postmenopausal women leading to breast cancer. I have no financial disclosures. And so just to begin, I wanted to discuss kind of the historical prevalence of HRT prescriptions throughout the US and throughout the world. So estrogen initially, it was first synthesized in the early 1900s. The first synthetic formulation came out in 1942. It was approved by the FDA. It went by the name Premarin. Specifically, it was a conjugated equine estrogen derived from pregnant mare urine. And throughout time, that even until now, it seems like that's a predominant form of oral estrogen being prescribed. So after 1942, after it was first approved, we see over here, the prescription rates really did take off. And then in 1975, there were multiple observational studies that came out linking oral estrogen, unopposed estrogen, to endometrial hyperplasia, as well as endometrial cancer. And then we saw a little shift in terms of prevalence. At this point, we found out, the scientific community, that progesterone can counteract these effects, and thereafter combined HRT was being prescribed in the form of estrogen as well as progesterone. And we see a pretty remarkable takeoff in HRT prescriptions. I think in the 90s it was the most widely prescribed drug, Premarin was. And then all of that changed. So in 2002, we had the result of the WHI study. It was the largest randomized control study that came out looking at the effects of hormone replacement therapy on women's health. And I'll go into the findings right now, but we see this precipitous and marked decline of HRT prescriptions right here and still currently. The WHI trial, what was this trial? To date, it's the largest randomized controlled trial in terms of women's health, analyzing the effects of hormone replacement therapy. It was a pretty broad and wide study. They enrolled over 160,000 women. We'll focus for this talk on the HRT segment of this. There were two cohorts that they tested the effects of HRT. Their primary outcomes were cardiovascular disease as well as breast cancer. So in the first arm, we have combined hormone therapy. It involves estrogen as well as progesterone. And then we have the other cohort, which is estrogen alone. These are stratified based off hysterectomy status, where estrogen alone was given to women who had a history of a hysterectomy. So down here in the timeline, we can see that the women that were prescribed the combined treatment, their study had ended prematurely in 2002. Why was this ended early? They had seen an increased incidence of breast cancer in this cohort. And then 2 years later, we have the estrogen group that was also stopped prematurely due to increased incidence of stroke that they had seen. And there's been multiple follow-up studies from within the past 20 years, which we can talk about as well. So a lot going on this slide. As we can see, they measured a plethora of outcomes in terms of HRT, but we'll focus more so on the invasive breast cancer. So we do see an increased hazard ratio in terms of the combined hormone therapy use at 1.24. So essentially, this is a relative risk increase of 24% in the combined group compared to placebo. And when we look down towards the estrogen alone results, we do see pretty discordant results, kind of divergent results when we look at breast cancer down here for the estrogen alone trial. This hazard ratio is 0.79. So essentially a relative risk decrease of 21% in women who are receiving estrogen compared to placebo. And when you stratify this for the younger age group of 50 to 59, we do see more beneficial results for the younger age group. So after 20 years, in terms of the combined HRT trial, there weren't much changes in terms of results. There was still a significantly increased risk of breast cancer for the combined HRT group. What I'd like to focus on in this talk is the estrogen alone. So initially there was a non-significant reduction of breast cancer. This was cited at 21% compared to placebo. However, 20 years later, when they followed up these women, the decreased risk became significant at 22%, and there was also a new development of a statistically significant decrease in mortality from breast cancer, and that was at 40%. I just want to point out this right here, this top left, these were the initial study results in 2002 that really dictated what happened in terms of clinical judgment, the effects from the media, and just widespread public outcry that estrogen or hormone therapy leads to breast cancer. These were the results that kind of led to that. And when we look closer at the study and kind of limitations, the average age of women recruited was 63. This is over a decade past the average age of menopause that most women are undergoing. 70% were classified as overweight or greater, and roughly half were classified as current or past smokers. Additionally, there was only one form of oral formulations that were used in both studies, the conjugated equine estrogen as well as the medroxyprogesterone acetate. It seems like these were generalized to all forms of HRT. And then further, the initial results seem to have focused more so on relative risk as compared to absolute risks. When we distill those numbers down, the absolute risks seen in the initial combined HRT study come out to be 9 over 10,000, which is a 0.09% absolute risk. This chart here just shows kind of the effects of confounding variables when you kind of stratify women based off past hormone use versus any use currently. The results really do change. It's just something to think about. And there's been a multitude of other studies that have been done on postmenopausal women's health. The Nurses' Health Study as well as the Million Women Study. These were studies that were more so observational and prospective studies that had pretty similar findings that any form of hormone therapy, either estrogen or combined therapy, both lead to breast cancer or have an increased incidence in breast cancer. These, however, were not randomized controlled trials, so it's limited in terms of guiding clinical judgment or treatment modalities. And just focusing on more so wider effects of estrogen, these results are after the 20-year follow-up. We see a marked, list of beneficial results or effects of estrogen. We see a decreased risk for all-cause mortality, coronary heart disease, hip fractures, osteoporotic risk. And when you look closer, these reductions become amplified when you select for the younger women aged 50 to 59. On the other arm, there are some risks associated that we're seeing. We saw increased risk for DVT, pulmonary emboli, as well as stroke, which the original estrogen alone study was stopped for. These, however, were not statistically significant throughout the trials. And that leads us to individuals who should not take HRT, anyone with a past history of breast cancer or current suspected breast cancer, ovarian or uterine cancer, any undiagnosed abnormal vaginal bleeding, liver disease, and maybe the primary concern a lot of people have is the risk for venous thromboembolic disease, which is supported by studies. However, there are alternative formulations of estrogen besides oral estrogen. There's been multiple studies on transdermal estrogen and its risk on VTEs. These two studies here, this was a 2019 nested case control study with over 80,000 participants. These women had a history of past VTE, however, it found no increased risk with transdermal estrogen use. And this similar study found results that were the same over there. And so this all brings me to the crux of this presentation, which is why is it that currently HRT prescription use is still on the decline? This was a study survey done by the National Health and Nutrition Examination. It showed that over the past 2 decades, HRT prevalence in the subset of women over 52 has declined from 26.9 to 4.7%. And what is even more interesting is that the proportion of estrogen alone is lower than before the WHI trials were released. Given the findings I just presented, you would expect that estrogen alone would be increased, but it's coming down. And the estrogen and progesterone proportions are also, they're coming up. You would expect those to go down, since those were the initial study results that had noted the increase of breast cancer. And they also looked at other factors such as age, race, and socioeconomic status. All racial groups had seen a decline in HRT use. Most notable non-Hispanic Black women had the greatest relative decline in HRT use, as well as overall prevalence at 0.5% of their current, the study sample using HRT postmenopausally. It also correlated with a higher prevalence correlated with income and insurance status. And there was a study done not too long ago. It was a 25-year multiracial cohort study that found that Black women, on average, had more frequent, severe, and persistent vasomotor symptoms, and even earlier onset of menopause compared to their counterparts. And they consistently were found to be treated at a lower rate. Multiple contributing factors can be involved in this, such as barriers to healthcare, implicit bias in providers, cultural differences. So it's imperative that as providers we remain aware and cognizant of how we can, avoid these factors. And just to summarize, so this is a cumulative table about the combined hormone use as well as estrogen use. In that WHI trial, we see pretty obvious trend here with estrogen alone, significantly decline or decreased risk of breast cancer as compared to the combined hormone therapy. So current professional societies, majority of them do have the indication of menopausal treatment to treat vasomotor symptoms. The Menopause Society in 2022 released a statement: hormone therapy remains the most effective treatment for vasomotor symptoms. And also, surprisingly, it has been shown to prevent bone loss and fracture. It seems that most other professional organizations do not have that recommendation, where it could be maybe seen as a preventative medication for osteoporosis. And the latest updates from those original WHI authors, there's an article in JAMA last year. Their position is that hormone therapy is effective for treating moderate to severe vasomotor symptoms, and they support the initiation of hormone therapy before age 60 for women without contraindications. And in summary, so as we can see, HRT replacement in postmenopausal women is a pretty complex, multifaceted topic. The initial 2002 results had a widespread effect on public perception as well as clinical decision-making, kind of lots of feelings of fear during that time. It seems like these results or these effects continue to remain. The subsequent 2 years later trial, or the results 2 years later, showed divergent results, and basically not even an increase in breast cancer risk. They more so showed a decreased risk. So with all that said, HRT prescriptions continue to decline, as well as the proportion of estrogen alone treatment also continues to decline. There's been multiple other formulations that are being researched. I think, so 2 years ago, there was a neurokinin 3 antagonist that was approved by the FDA for a severe vasomotor symptom management, which has shown good response, and that's a non-hormonal agent. And just in closing, for all management of HRT, shared medical decision-making should be tailored to an individual's age, their symptoms, last menstrual period, personal history, breast cancer history, as well as their own expectations and preferences. So that's about it. So thank you.
Any questions or comments from anybody?
Would you use estrogen if it were you?
Could you repeat that?
Would you use estrogen if you were in this situation?
I think so. Yeah. If I had severe symptoms and, they were not managed with other medications, I think I would. The data was shown that less than 5 years of use was more precipitously indicated with a more decreased risk of anything developing, as well as initiating HRT at the age of less than 60.
I think that, one of the issues, which we didn't show maybe we should have showed the clip, but when that original Women's Health Initiative study came out in 2002, the investigators had a press conference before they had published any results, and it hadn't been peer-reviewed or anything. And they basically said in the press conference that all women should stop taking hormonal replacement therapy based on the study. All women, no matter what they were on. And it wasn't for another year or two, I guess, when it was subsequently published, that everybody looked at the data, that it really just, they were talking exclusively about the estrogen. It was all based on the estrogen plus progesterone group and not on the estrogen alone group, which actually had a decreased incidence of breast cancer. But that stuck. And honestly, it stuck for me. I think it stuck for a lot of people. My wife, who's a physician, also thought that estrogen increases breast cancer risk in hormonal replacement therapy. I think it's a common belief amongst both providers and women, and it's pretty much all based on misinformation, I guess, that was given at the time of the original study, which is kind of sad because there have been a lot of women that have probably needed treatment that didn't get it. Not every woman obviously needs treatment for menopausal symptoms, but there are a lot that have really severe symptoms that probably have had a really bad quality of life because of it. So, anyway, you got it. Okay. Any other questions? Yeah, or comments?
I think we talked about this before, but the transdermal versus oral supplementation, was there benefit to the oral versus the transdermal?
Are you asking what?
Yeah, for the menopausal symptoms. Did you?
Yeah, so there were studies showing that transdermal.
Can you repeat the question?
Yeah, the benefits of transdermal versus oral estrogen in terms of managing vasomotor symptoms. Yeah, I did, research that, and there were studies showing that transdermal use of estrogen, it was effective for treating vasomotor symptoms, but I think the oral estrogen is more effective. But it's a give and take. If you have a history of VTE, you most likely shouldn't be taking oral estrogen. It can increase your risk. So.
All right, I guess it's time to vote. Estrogen replacement therapy in postmenopausal women increases the risk of breast cancer. So how many think that this is true? How many think you still think it's true?
Possibly plausible.
Plausible, okay. Anybody else think it's plausible? How many think this is busted? We're talking about estrogen alone, yeah. I don't know, what do you think? Is it busted?
I think so. It's close to.
You're on busted, or
Let's keep people away from
you think it's busted? All right.
anybody having access to them.
All right, I think what we'll do is we'll do this one.